Okay, so the first talk is by Dr. Jasmin. Madam will be speaking on drugs causing CSR. She is working as associate professor in Government Medical College, Paripalli. Over to you, ma'am.
Good afternoon, all. First of all, let me thank Dr. Papa for giving me this opportunity. My topic is drug causing CSR. CSR is the fourth most common medical retina problem after ARMD, diabetic retinopathy, and branch retinal vein occlusion. About 15 to 20 years back, if we diagnose a CSR, we would be happy with the diagnosis. But today, with the newer multimodal imaging techniques, it could be a tip of vastly hidden iceberg of pachychoroid disease spectrum. CSR, by definition, it is previously we thought it is a retinal disease, but now we know it is a chorioretinal disease with serous detachment, which is associated with one or more areas of leakage from the choroid through a defect in the RPE. What is pachychoroid spectrum? Pachychoroid clinical spectrum is a group of macular disease that manifests a similar choroidal findings, that is abnormal and permanent increase in choroidal thickness. CSCR, pachychoroid pigment epitheliopathy, pachychoroid neovasculopathy, and polypoidal choroidal vasculopathy are the entities of pachychoroid clinical spectrum. This is the pathophysiology. The basic pathophysiology involves choroidal thickening, vascular congestion, altered choroidal blood flow, and choroidal hyperpermeability leading to retinal pigment epithelial decompensation and subsequent neurosensory detachment. This is anatomy showing the choroid and retina. There is leakage from the choroid vessels. It will compress the choriocapillaries and causing stretching of the RP and causing multiple defect in the RP, which cause serous detachment. These are the multimodal imaging techniques: fluorescent angiography, ICG, fundus autofluorescent, OCT, and OCT angiography, which detects the choroidal neovascularization. Today's common classification is acute and chronic CSR. Depends upon the duration of the CSR. But this is the revised classification based on the multimodal imaging techniques. It is classified as simple, complex, and atypical. This is a fundus showing serous macular serous detachment. And this is the multimodal imaging techniques like autofluorescence, FFA, and OCT. First picture shows the acute CSR, and second comes the chronic CSR. You can see the hyperreflective spots in the outer detached retina. It indicates the chronic CSR. This is the ICG picture. And this is a table from the Yanov textbook showing the risk factors of CSCR. You can see the systemic conditions and medications. This is a common drugs which cause CSR. First and foremost is the steroid. Steroids have strong relation with the CSR, both endogenous and exogenous. Exogenous, any route can produce CSR, like oral, intravenous, intranasal, even intravitreal also produce CSI. Yeah. Second is the antihypertensive drug, example minoxidil used for the androgenic alopecia, which also cause CSR by increasing the hyperpermeability of the choroidal vessels. Third comes the sympathomimetic drugs, the common drug which we use in common cold, that is pseudoephedrine, then ephedraf, which is found in bodybuilding products. Then next comes the prostaglandin analogs, what we use in as anti-glaucoma medication. It mimics a VEGF-like action, that is vasoendothelial growth factor. It will increase the choroidal permeability and cause CSR. Next is the sildenafil. It is a phosphodiesterase inhibitor used for erectile dysfunction. Another comes the anti-cancer drugs and antipsychiatric drugs. So this is a study showing central serous chorioretinopathy induced by drugs metabolized by cytochrome P453AA4. Cytochrome P450 is an inducer may improve the CSR, and inhibitors can aggravate the CSR. So for example, rifampicin is a cytochrome inducer which we use for the CSR treatment. Another study which shows, it's a study of FDA adverse event reporting system, which shows most frequently reported drugs. Dermatology drugs are most common for causing CSR because dermatologists are mostly using steroid ointments. Second comes the anti-tumor and immunological agents. Third is the hormonal preparation. Again, among the top three steroid drugs, first comes the prednisolone, 44%, and fluticasone, 8.9%, and methyl prednisolone, 8.2%. Then how will you manage drug-induced CSR? Clinically, CSR, drug-induced CSR will not show any difference from other CSR. So history taking is very important. You should ask about whether they are using any ointment, any cosmetic drugs like that. History you should ask. Then ask them to stop the drug or change to another drug, use alternative drugs, or if not possible, at least reduce the dose. Then convince about the risk to the patient and also to the physician. Convincing the physician is very much important. Other causes of SRF in macula, you should rule out other causes also. Dome-shaped macula, always usually sometimes associated with SRF. Then VKH, posterior scleritis, sympathetic ophthalmia, optic pit maculopathy. If you diagnose a CSR, always look the optic disc for any pit. Then tumors, acute vitelliform lesions, hypertensive retinopathy. So these things should be ruled out. Then these are the take-home messages. History is very important. Always you should ask about the treatment history, whether patient is taking any drugs which are causing CSR. Second is, you should always rule out VKH and posterior scleritis or sympathetic ophthalmia, because the treatment for VKH and posterior scleritis is steroid, which can aggravate the CSR. So rule out those causes. Then you should always think about other pachychoroid spectrum. It may not be a simple CSR, it could be a part of the pachychoroid spectrum. Thank you for the patience.
Thank you, madam, for that information.